Hello and warm wishes to all of our viewers around the world. Welcome to the 14th episode of our webinars of Endo Explained. At the outset, I would like to thank all of our viewers everywhere and all the chapters of EndoMarch internationally, all of the patients with endometriosis, their families, their friends, all the country captains, country presidents, ambassadors, and volunteers for all of your efforts to raise awareness about endometriosis. We especially like to thank and dedicate this chapter, this episode of the Endo Explained to our sister chapter of France, of EndoMarch, and all the members of the EndoMarch France, the president, the volunteers, the captain, the ambassadors there, and especially to Dr. Chrysola Zacharopoulou for her efforts, who is now a member of the Parliament of the European Union and has been very able and instrumental to bring this issue to the attention of all the way to the government of France, even to the top level of President of France, President Emmanuel Macron, that to declare that endometriosis is indeed a social issue, something that we have been saying for years. Why is it a social issue? Because of two reasons. One of them is significant amount of problems and pains and organ dysfunction that it is bringing to millions of people around the world. And another problem is infertility, because infertility in some countries could be a social problem with the low birth rate, negative birth rate in many developed countries. For example, 1 out of 10 to 7 couples who try to have a child, they have problem getting pregnant or have problem with miscarriage. That could be a social problem. And in our opinion, over the years, we have noticed that if a couple, all of their tests are normal, the wife is normal, the husband is normal, they don't have any pain, they don't have any issues, and still they don't get pregnant. In our experience, we have noticed more than 90% of these couples have endometriosis, and that these group of patients, they could be helped significantly by proper intervention. And in the next several episodes, we want to address this issue. And we are lucky today to have a very brilliant infertility specialist, Dr. Aimee Eyvazzadeh, that she is being known and loved by the name of Dr. Aimee by her patients, that she is one of the front runners of acknowledging and discovering that many of these patients who do not get pregnant and have no symptoms at all, they have endometriosis. And when the endometriosis is properly addressed, the success rate of these women getting pregnant is very high. To her credit, Dr. Aimee, as you know, she is very well known by many of you, by her multiple advocacies for the infertility patients, and has been trying to educate the whole public for infertility by many of her programs, and it is very easily, you can see it on YouTube, on Instagram, on different television programs, And the most prominent one is egg whisperer that would educate the couple about endometriosis. So we were lucky to have her, and we are going to give her the stage that she advocate and talk and speak about her experience in this regard. We have had the good luck of working with her and several of her other RPI colleagues that they are interested in this issue. Also today, our colleagues and fellows, Dr. Shruti Agarwal, that has been for the past 2 years doing a fellowship in endometriosis with us. Very brilliant. You have seen her before, and also Dr. Lee, who is doing a fellowship this year, and then she is going to join the program in Texas, heading the minimal invasive and surgery program in Texas next year, and she would tell you more about it herself. And Dr. Tavallaee, who is not only a gynecological surgeon training to become endometriosis specialist, she has had also, beside gynecology, residency in endometriosis at Stanford. So they are all joining us. So we welcome you again. Thank you for joining the webinar. For the previous episode, you can easily go to the webinars on the top and find the webinars, and you can watch any previous episode you want. Thank you again, Dr. Aimee. It is a pleasure to have you. Please, you have the podium. We would appreciate it if you proceed and explain your involvement and how you decided to help the patient with endometriosis and the issue of your experience, and how do you address that? Thank you.
Of course, I think when it comes to having patients in my practice suffering from infertility, they come to me because they want a reason and they want a diagnosis. They want an explanation as to why is what happening to them. And unfortunately, as women, our symptoms are often ignored, and it can take years before someone gets properly diagnosed with endometriosis. And we know far too often in our experiences together how endometriosis can affect implantation. Endometriosis can block fallopian tubes. It can decrease egg quality, causing a less number of mature eggs, for example, and a higher rate of having embryos that are not genetically normal. So when you've already gone through so much to have a baby, and in some cases it can be even multiple IVF cycles, it's imperative for me when I'm planning something for a patient to make sure that I have ruled everything out, and that includes endometriosis. So that's why there are some tests that I do. For example, the Receptiva DX test, if I suspect that someone might have silent endometriosis, or I send them to you to see what you think as far as whether the patient clinically might have some physical exam signs of endometriosis that I can't pick up, because I have certain tools in my toolbox, and I feel like you obviously can pick up on some things that I can't necessarily pick up on all the time. And I'm always just so grateful for the work that you and your team does to make my patients parents. So we've had great fortune and so many success stories where patients, for example, have had IVF cycles that don't work. Then you do surgery on them, and then they come back to me and they get pregnant through either IVF or even naturally. And sometimes, when you tell a patient, Aimee, she can get pregnant now. And in the beginning, I was a little bit doubtful. I'm like, there's no way that this patient with this endometriosis can get pregnant. And then after surgery, sure enough, we have so many countless stories of patients who are then able to conceive on their own. Not everybody, but there are definitely some pretty amazing stories out there. And so patients sometimes will do IVF with me, have embryos stored, do surgery with you, get pregnant naturally, and then we've saved their embryos for their future. So that's pretty exciting for me. So if there's anyone out there that feels in their gut that they might have endometriosis, or you just don't know what's going on, I think it doesn't hurt to meet with someone to ask them, have you ruled out endometriosis for me? especially if you have pain or if you're having implantation issues or problems with embryo quality, I think it's worth it to explore endometriosis as a possible factor.
Thank you very much, Dr. Aimee. Dr. Aimee, why do you think it is that in general, as you said it yourself, there is you cannot deny the success of these couples who get pregnant after many failed IVFs in some of the best centers, and you treat them and they get pregnant. And why do you think, number one, the mechanism, what it is, and number two question is, why do you think this is not more known among many infertility specialists?
Yeah, I'm hoping through more awareness, like the seminars you're doing, and more patients that are speaking out about their success stories, that hopefully more fertility doctors will agree. And I think it's hard because I've personally heard other fertility doctors say, oh, endometriosis won't cause this or that. And we know that it can. So I think that, with more experts like you also, talking about how it can affect fertility, I think people will start to offer patients a workup for endometriosis more and more. And I'm seeing it across the board, either surgery or medical treatments like Orlissa or Depo-Lupron or Letrozole. And the mechanism is, I think a lot of it is just inflammatory. It's inflammation that endometriosis can cause that can decrease implantation rates, increase miscarriage rates. And the hardest part for me is getting healthy eggs when someone has endometriosis. And so I'm not surprised, but I'm pleasantly pleased, I should say, when a patient has endometriosis surgery, especially if it's more severe, then they come back and they make beautiful embryos for me. So I think a lot of it has to do with inflammation, and that's how it can affect egg quality and make things not work the way I would want them to work the first time for them.
Thank you very much. There have been, as you know, the many couples with, everybody thinks endometriosis patients that have pain, but there are many patients with endometriosis that they have no pain at all. Many couples, many of your patients, the husband is fine, all the tests are okay on the female side, the HSG, everything is normal, and they are completely asymptomatic. In our experience, more than 90% of these patients, when we see them, they have endometriosis. And it would be very typical for you, I take it, that when you have a couple like that and you see they have had failed IVF, everything is okay, and tell them, hey, you might have endometriosis. How do you talk to those patients?
Yeah, I mean, I feel like the way I talk to them is I talk to them about how common endometriosis is for so many reasons in terms of the things that we're exposed to in the environment. And then also when you've taken so many hormones through so many cycles, I feel like IVF medications can also sometimes stimulate endometriosis. So those are the kinds of things that I bring up. And then I also tell them, just because you have endometriosis does not mean you cannot get pregnant and have a healthy pregnancy. It just means that you should be more thoughtful about the approach you take. And it's kind of a catch-22. And I'm sure everyone who's listening right now understands what I'm talking about. Sometimes people say, oh, you have endometriosis, so go ahead and get pregnant. But when you have endometriosis, it's harder to get pregnant because pregnancy can be a treatment for endometriosis. So I find sometimes it's mean to tell someone who has endometriosis, go get pregnant and that's going to fix it. They just aren't ready yet to get pregnant, or they're ready for sure, but sometimes it's just a little bit harder. So I explain it in those terms, and I feel like people can understand that it's not their fault. It's something that could be environmental and genetic, and it could be stimulated by IVF medications. And that's why it would be important to rule it out before, let's say, you transfer your very last embryo, or you rule it out before you go through all your embryos and then have to do another IVF cycle to have a pregnancy.
Thank you, Dr. Aimee, you are so precise. Dr. Aimee, one thing that I would really appreciate it if you explain you have been so outspoken and advocate to raising awareness about infertility couples. Would you please talk about Egg Whisperer and your previous programs that you have done, and many of them are very, very watched by thousands and thousands everywhere. Could you please, if you don't mind, explain some of that to our viewers?
Absolutely. So I have
How could they get involved?
Of course. So I have a podcast, and you have been a very big part of that podcast. You were a guest not that long ago. And then I also have a YouTube show. And then I have a Q&A series that people can send questions into. It's asktheeggwhisperer.com. And my favorite is actually my classes. So I teach IVF classes. I call them master classes. And it's at the Egg Whisperer School. You would think that I could be more creative with the names here, but eggwhispererschool.com. You can go there. You can learn about fertility. I have a Tushy class. Tushy method is one of the methods that I teach people. All the tests that you have to do before you get pregnant. I don't know if you can see it back there. I think it says Tushy method back there, but it just raises awareness about getting your tubes checked, getting an ultrasound to rule out endometriosis if it's present on ultrasound, getting your sperm checked, your hormones, and then lastly, your genetics. So those are the kinds of things that I do to teach people, build awareness. I make catchy phrases so that people can hopefully sometimes or always laugh and smile as they think about something that sometimes brings a lot of sadness and depression.
Thank you, Dr. Aimee. Dr. Agarwal, if you know, she did some work with the Receptiva test, many of them your patients, and also she has a comparison with an app that we have developed. It is called Nezhat Endometriosis Advisor that diagnoses endometriosis with more than 90% accuracy. It is completely free all around the world. And she did some of the work, and also still is continuously working on that area. And I think she has some questions from you. And I would ask Dr. Agarwal to go ahead and ask Dr. Aimee.
Hi, Dr. Aimee. Good morning. I think I wanted to ask, what do you think about BCL6? I know you are very well aware and you have it performed on your patients all the time. You test for BCL6, but we don't see it from other fertility doctors as much. So how would you educate patients on whether they should ask their doctors to test for this to see if they have endometriosis?
Yeah, I mean, I'm actually seeing an uptick in fertility doctors doing it across the country now. So we're going to see more and more patients getting this test done as people are, waiting longer to have babies. Their embryos are so precious. I think doctors are now willing to, or they agree that maybe doing this test makes sense, especially when they're doing other tests at the same time. They can easily do that. The BCL6 test for me, if someone has obvious endometriosis, I mean, I don't know how helpful it is for someone who has endometriomas, but in someone who is having implantation issues or preparing for a transfer, I think it can be a helpful test to do, even if you haven't quote unquote failed one transfer. I don't want people to fail even one transfer. And I know people say, oh, she's never failed a transfer. Why would you do this test? And my personality is I'm not going to discuss this test with somebody after a transfer doesn't work. I want them to know the menu of tests that they can choose from at the very beginning, and then they can choose for themselves if they feel like that test resonates with them and they want to do it. And at the same time, it is not a perfect test. I mean, Dr. Nezhat and I have had patients where we think they have endometriosis. The BCL6 test, for example, is negative, and then he does surgery and sure enough, they have endometriosis. So I always tell patients, if the test is negative and you think you have endometriosis, the test could also be wrong. And I know there are other tests coming out that might be better than the BCL6 test, but that's kind of how I use it to guide treatment. It helps me change protocols. It helps me direct patients to Dr. Nezhat. It makes me look at the fallopian tubes more closely before a transfer. So it teaches me a lot about a patient before a transfer. But again, if a patient doesn't have access to that test because their doctor won't do it, there certainly are other doctors who could do it for you, like your OBGYN even could do it for you if your fertility doctor doesn't think that it's a tool that they want to apply in your case.
Right. I think I totally agree with you when you said that When it's negative, it doesn't really mean much because you could still have endometriosis. We see that with our own research. We looked at these patients who came to us that were positive for BCL6, and we wanted to see if you were positive for BCL6, would you be positive for endometriosis? So the correlation between a positive test showing definite endometriosis is very, very high, but that doesn't mean that a negative test won't show you endometriosis as well. Because we looked at about 40 patients and it was 96%, all 40 of them ended up having endometriosis on pathology afterwards. During the time of the study, we saw it was 96% positivity, but as we followed these patients further on, it was all 40 of them. And then they all ended up getting pregnant, either naturally or by IVF. So it was a very good predictive factor. And also mixed with the Nezhat app, with the Endo app that we have, when you score over 90% and you have BCL6, your probability of having endometriosis is, I mean, it is very, very high, like higher than 95%. So I definitely agree with you that when it's positive, it's a great thing, but when it's negative, it doesn't really mean that you don't have endometriosis.
Thank you very much, Dr. Aimee. That is very important. Here I take the prerogative of confirming exactly what Dr. Aimee is mentioning. There are, we explain for the patient the benefits and the risks of each option. And then if you have one hammer, everything is a nail. But you have to know the pros and cons of each option. The surgery should be done by somebody who is really, really an expert, and to diagnose all the endometriosis properly and do not cause any harm. And if it is done properly, the results are, in our opinion, are much, much better and faster and immediate and longer lasting than hormonal treatment. Because when you remove the endometriosis, you essentially decrease the inflammation. Endometriosis is a progressive disease. And as Dr. Aimee very aptly said, many of the infertility treatments, because of the producing, or they produce significant amount of estrogen, and estrogen feeds the endometriosis and makes the endometriosis worse and worse and makes it even more advanced. So the fertility medication that the patient receives may increase, not always, but very often. Endometriosis is estrogen dependent and endometriosis gets worse. So if we go and treat it surgically, we remove the whole endometriosis. By removing the whole endometriosis, they stop the progression of the disease. And we not only benefit the patient from the long-lasting benefit of endometriosis, the inflammation goes down, and she could go and start trying to get pregnant immediately with a shorter period, rather than giving her own hormonal management that you have to give them at least 3 months. And by giving the patient that hormone, you don't eliminate the disease, you decrease it. And not on everybody, not all the patients that they go on hormonal treatment respond. Some of them, they are not receptive. Actually, a good portion of them, they don't respond at all. And many of those 40 patients that they did get pregnant, and Dr. Agarwal was referring, and that was published, and she is working on some other papers in that regard, they had already received hormonal treatment as well. So hormonal treatment, it has its limitation. It doesn't always work on everybody. You have to give it to them longer. And at the same time, the hormonal treatment, it is probably it is a good idea to use it when there is nobody who is there to do the surgery. It might be a good idea, or if there is nobody who do a proper surgery, or if the patient has contraindication for surgery. But in general, in our opinion, surgery is the best choice if the patient is a good candidate and a good surgeon is available to be thoroughly treating the endometriosis, because another benefit is that patients with endometriosis, they have 2 to 3 times higher chance of malignancy. And by removing the endometriosis, hopefully you decrease that patient, her chances of having future cancer. That is another benefit. There's a caveat here there that the patient should be aware that not necessarily removing or excising the whole endometriosis is always the option. For example, when it comes to the ovaries of a young woman who wants to get pregnant, those ovaries have to be treated very differently than other areas. And that is, we have heard often infertility specialists that are like Dr. Aimee are very aware of that. But you have to be cautious. It depends how you are dealing with endometriomas. So Dr. Tavallaee, Dr. Aimee is one of our fellows. She did also some training in pathology, and she wanted to ask you a question also.
Hi, Dr. Aimee. Great
Hi.
to see you. Thank you for joining us.
Of course.
So I have one question that a lot of our patients ask when they come see us, and that's about like the time of freezing eggs and doing the surgery. So there are studies that show that the quality of eggs actually get better after we do the surgery. So that's one thing that we tell our patients. But at the same time, there are some of our patients who don't want to lose time, or they're like older and they say, oh, do I have to get my eggs freeze and embryos freeze before the surgery or after? I just wanted to know your opinion about how to counsel these patients.
I mean, I think it also depends on, like you said, their age, their hormone levels, how much ovarian tissue is actually there, and their willingness to do multiple IVF cycles or egg freezing cycles. So I sometimes ask people to consider doing both. So do a cycle of IVF or egg freezing first, and then about 6 weeks later, whenever Dr. Nezhat thinks is the best time, then do another IVF cycle after surgery. So I've done it both ways for patients, and in some patients, you know, for example, where they have such a large endometrioma that I think it might be very dangerous, for example, for them to go through treatment. Let's say they've had severe pain before, you know, just from the cyst rupturing, or not necessarily rupturing, but maybe leaking or getting rushed to the emergency room. Like, I don't want any of those emergencies to happen during an IVF cycle. Then I'll definitely recommend that they do surgery first. But it's a real fear because of things that patients have heard about other people who've done surgery. Then they have a much lower egg count afterwards. And so they're fearful also of losing their ovary. But just like Dr. Nezhat said earlier, it is so important that you're going to a fertility-minded endometriosis surgeon. So I've had patients who've gone to somebody and they leave the operating room with no ovary because the doctor didn't do anything to save that ovary. They just removed the entire ovary rather than just removing the endometrioma. So I always reassure my patients that I actually don't think I've had one patient leave Dr. Nezhat's operating room with an organ removed. In all these years, the surgeries that Dr. Nezhat and his team does for my patients is always fertility sparing, because he knows how important having babies is for them. But not every surgeon has that approach. And I think that, you know, going through all the worst case scenarios in our heads is normal, but I think it's important to verbalize that with your surgeon. And then the other thing is to go through all the worst case scenarios about your fallopian tubes as well. No one wants to wake up not realizing that a fallopian tube could be removed. And that's a very careful, thoughtful discussion that I know you guys have with all my patients as well. And I do also just let them know that, you know, endometriosis can affect your fallopian tubes, and it might be helpful to have one removed. You can still get pregnant from the other side. But when it comes to transferring an embryo, having abnormal tubes can really get in the way.
Thank you very much, Dr. Aimee. One issue that I like to also ask you, what do you think, why do you think the couples, do you think the rate of infertility is increasing, and why do you think it is?
I mean, I know it's a controversial topic, but stress, I think, and right now we're living in unprecedented times with people undergoing, they're very, very stressed. And I think stress and then the environment and all the garbage that we're exposed to from the minute we're in utero, all the plastics, I feel like that has a lot to do with potentially why we're seeing more endometriosis. And then society, obviously, the trend is for us to wait longer to have babies. And the longer you wait, the higher the chance that you'll have a problem like endometriosis as well, especially if you had it as a younger person. Then waiting longer to have babies, you're obviously going to have worsening endometriosis. And so many people say, like, why didn't I know this when I was younger? So I think a lot of that plays a role into why I think I'm seeing more fertility patients now more than ever, with some, I think, with more endometriosis than I saw maybe, 15 years ago. So I do think that the environment has a lot to do with it. Stress has a lot to do with it. And then also age-related infertility is a big part of it as well.
Thank you very much. And Dr. Aimee, do you think there should be a program or perhaps a national program that all the female patients who want to have children be given an option to freeze their eggs in the optimal time of getting pregnant? As you said it yourself, and we see it very often now, couples in their 40s and sometimes very early 50s, they want to have children of their own. How do you feel about that? And how do you think that should be addressed?
Yeah, I mean, I feel like we're going to see a huge trend toward a population decline in the United States. And I think the government, I predict, is going to play an active role in changing that and increasing the birth rate by incentivizing young people to freeze their eggs. I don't think it's going to be happening in the next 5 years or so, but I predict in probably 15 years, just like other countries are doing now, they're incentivizing young people to freeze eggs, and they're actually paying for it. So I would not be surprised if that starts happening here in the US, that people will actually get their egg freezing done for free, just so that as a society, we can continue to grow and support, everything that we need to support. Otherwise, Elon Musk will be taking us on SpaceX, or, Elon and Bezos to Mars soon, just because of what we're doing to this. Anyways, but you know what I mean. But I do feel that it's one of my egg whisperer golden rules that every woman by the age of 25 should have a fertility level check and get, some fertility tests done. And she should consider freezing her eggs if she is considering having children younger, even 21, if she has a history of endometriosis, having an ovary removed, or her mother went into early menopause, because there sometimes are some even 25-year-olds that wish someone had told them about these things sooner. And then I think by the age of 32, if a woman wants at least one baby and hasn't had one yet, whether you're married or not, should consider freezing her eggs. So I do think that egg freezing is a powerful tool. It's a great technology. It works. I do it a lot. I freeze a lot of patients' eggs and they come back to me and we use those eggs and they have healthy babies. It's not perfect. It's not an insurance policy, but it's a future chance at a pregnancy with better chances than you had at the age that you're at. So I always tell people, you want to be your own egg donor. So when you're 40 and 50, I mean, I'm not almost 50, I'm almost 46. And I feel like if I wanted a baby right now, I could have one, but I would have to use eggs that I froze when I was 32 years old. Unfortunately, I didn't freeze my eggs. Not that I want to have more babies right now, but I froze my sister's eggs when she was 32. So maybe I'll be calling her up if I want another baby.
Well, you are a good pioneer in this area, and you have done a very good job. And thank you for that comment. So, Dr. Aimee has a wonderful family. I let her talk about it if she wants, but I don't want to spill all the beans for you. So, and it has been a pleasure to know you and know your family. So, what role, I have another question, and I think perhaps one of my colleagues wants to ask you. It was about anti-Mullerian hormone. Was it Shruti, who was it? Any of you want to ask Dr. Aimee the question yourself, or do you want me to proceed?
No problem, sir. I mean, with anti-Mullerian hormone, we want to know, Dr. Aimee, what are your thoughts? Because sometimes patients just randomly have an anti-Mullerian hormone test done. They get a low number and they start freaking out about it, thinking that they're never going to get pregnant again. And these are younger patients and patients who are about to undergo an infertility workup. What would you say to patients who just have not had a single infertility workup and just have a low AMH in their hands and now don't know what to do?
Yeah, I mean, it also depends on your age, but I tell patients one snapshot in time doesn't define you. It doesn't define your fertility. And, the AMH can go both ways. You can have a high number and actually it could be a lab variation and wrong, and then you repeat it, and then it could be closer to what your true number is. So I tell patients to never just rely on one AMH level to guide your, fertility treatment. And then never do it in isolation. You want to get an ultrasound and have something called an antral follicle check done. So that's a measurement of the tiny little cysts called follicles in your ovaries. They kind of look like boba pearls in a boba tea, or chocolate chip cookies, chocolate chips in a chocolate chip cookie. We just count those little circles. Or someone said to me the other day, they're like, they look like little caves. I'm like, yeah, little caves with a tiny sparkling microscopic egg inside. So we take all that information, and then I tell patients, I'm not your fertility doctor for just today. I'm your doctor for 2 years from now, 5 years from now. I have a patient who just saw me yesterday. I'm now helping her with another baby, and I met her 12 years ago. So I froze embryos for her back then. So when I take the AMH, I use it to project someone's fertility for them. And I say, okay, well, this is what it means right now, but I can also tell you what it means to me based on everything I know about you 2 years from now. So I always talk to patients about how many kids they want. And then I kind of think through, well, how old are you going to be when you have your last baby? And what will your AMH potentially be then? And, how many IVF cycles should you do to give yourself the best chance of reaching your goals? Because we know that we have a finite supply of eggs, and we have not figured out a way to help women regrow them. So AMH, one day we hopefully will, but for now we still have to freeze eggs, do lots of IVF cycles for people to make sure that they have enough embryos for themselves. And until then, the AMH, unfortunately, is the closest thing to a sperm count that we have for a woman. And it's certainly not perfect. But that's what I would say. I would say, don't let that AMH define you. You're not your AMH level, and your AMH can be misleading because sometimes you can get a level that's not accurate or true for what's going on with your fertility.
Dr.
Thank
Aimee,
you very much, Dr. Aimee.
That's very well put.
Okay, go ahead, please. Go ahead, please, Dr. Lee. I just, before Dr. Lee, please don't forget your question. And if I want to give a comment about exactly what Dr. Aimee said, AMH, anti-Mullerian hormone. Personally, I agree with Dr. Aimee. I don't put much weight on it at all. We have had numerous patients with a very low AMH, very low AMH. Actually, too many to count our patients that after surgery, they have gotten pregnant. I vividly remember one patient who was a physician, and she was in her, I think, mid-40s. I don't want to give too much, but she had bilateral endometriomas, and it had been recommended that both ovaries had to be removed because they were pretty large, and she still had hope to get pregnant. And she came, and we did the ultrasound. We evaluated it. Indeed, the amount of ovary left was very little of the stroma. And prior to her surgery, AMH was very low, as Dr. Aimee said. I said, well, let's give it a try. We removed both endometriomas. We saved very little tissue which was left of endometrium of the ovary that we saved no matter what. We erred on the side of even leaving some endometriosis behind, but we saved both ovaries. That patient, after the surgery, she didn't get her period. And everybody thought she was in menopause. She came back, actually she was pregnant. That is a very, very pleased that she was a physician. So that is a very good story. So what I'm saying, that is an extreme, that she actually didn't even get her period, but she started ovulating and she got pregnant. She thought she went to menopause. But, and again, we have had other patients, I'm repeating myself for the purpose of better understanding of everybody and confirming what Dr. Aimee said, that do not let that defy the low AMH bother you. And if it is the process done properly, many, many patients get pregnant. Go ahead, Dr. Lee.
That's an amazing story. I'm so, it's so always so exciting when our patients let us know they're pregnant. Dr. Aimee, we, on the topic of AMH, I was wondering kind of what you see in your practice in terms of the AMH of patients with endometriosis, and if you notice that their AMH can be, different with your endometriosis patients versus your non-endometriosis patients.
I mean, I haven't noticed anything necessarily different. If an AMH is, let's say 1.0, I would expect a certain number of follicles, maybe 8 to 10. And I wouldn't say that if they have endometriosis, I personally haven't seen any difference in terms of how many follicles I could get. So I personally haven't seen a difference. Obviously, if they're taking a medication like Lupron or something like that, certainly it drops the AMH level significantly. So I always tell people, don't check your AMH when you're taking a medication like that. It's not going to be helpful, but afterwards you'll see it go back up.
Thank you very much, Dr. Aimee. Dr. Aimee, incidentally, we had several of our, actually we had 3 very wonderful couples of patients of yours that over the years we had treated, and they achieved pregnancy because of your effort, and after the surgery with collaboration together, and they were part of the program. Unfortunately, at the last moment, each of them had an issue that they couldn't be on the program today. But we had several of our patients. So, and there are some questions from the viewers also that perhaps Zoe yourself, or you can ask Dr. One of the fellows, please ask Dr. Aimee those questions.
I actually have one from the chat that I think could be really helpful to a lot of people. Someone asked, basically, when you're going to see your doctor, you have infertility and you're concerned you may have endometriosis, what should you be watching for? What should you ask your doctor? What type of evaluation, what exams or studies should be done if you have infertility and you're concerned that you have endometriosis?
Yeah, I mean, I would just ask the doctor, first of all, what have you ruled out? What tests have you done? What do they mean in my, what do you know about me? What do they mean for me in my situation? And then you can simply say, based on everything that you know, do you see any signs that I could have endometriosis? And sometimes on ultrasound, we can see things like little cysts called endometriomas that we have talked about today. Sometimes I get a sense that the uterus might be, the term we use is boggy or slightly enlarged, and that could be a sign that a patient has adenomyosis. And we know that that is related to endometriosis. We also look at the positioning of the ovaries. So if I see that the ovaries are kissing or touching each other behind the uterus, for me, I say, you know what, it looks like there could be some scarring here. The ovaries seem to not necessarily be, kind of flopping out to the sides. They're kind of right behind your head, and the head meaning the uterus. I do a lot of pantomimes here in my office, but those are signs that someone might have endometriosis. So that's kind of what you can ask your doctor is, do you notice anything about the position, the shape of my uterus, the way it's tilted, that maybe it's tilted that way because of endometriosis? When you look at my ovaries, do they look like they're free and mobile? Are they positioned in a way that makes you think I might have endometriosis? So you can simply ask those questions, and then obviously, you know, go to your team if you still have a gut feeling and you don't feel heard. Because I have patients that are like, I literally asked the same thing and everyone said that I was normal. And then they come and see me and I'm like, yeah, that left ovary looks like it's stuck behind your uterus. Yeah, I can see you have this area. You can see the asymmetry in the walls of your uterus. It looks like you have adenomyosis. So if you don't have someone like me or your team who can advocate and help you, perhaps ask for a pelvic MRI. Sometimes if done, sometimes people can pick up things in the uterus, but also that's also not a perfect test also.
Thank you very much, Dr. Aimee.
You're welcome.
There was more questions. Could you please ask the one in the chat? Was a couple of other questions.
There is actually one from the chat that one of our participants is asking, is it wise for someone who had undergone multiple surgeries because of endometriosis to try for kids via IVF, or chances are slim, especially if the AMH is poor?
Yeah, I mean, if someone has had multiple surgeries for endometriosis, you still have a chance for a baby. I mean, I've had patients referred to me from Dr. Nezhat who've had multiple surgeries, and there's one amazing success story that I can think of right now. And they got pregnant through IUI with me and had a lovely pregnancy. So I think that all options are still out there for you. You have to ask the doctor if there's any barrier to fertilization. I'll make a joke here. I know it's a little too early in the morning here for me to make jokes, but I say eggs are effed in the fallopian tube, not the kind of F word you're thinking about. The F word is fertilized. So as long as the endometriosis hasn't affected the shape and the way your fallopian tubes work, then when two people love each other, if you're in a heterosexual relationship, miracles can happen and you can make a baby. But if you're thinking that it might be better to do IVF after multiple surgeries, that is still also an option for you as well, as long as you have eggs and a doctor that's willing to work with you, even if you have a lower egg count. And you should ask your doctor that, because there are some doctors that they will say, oh, you need to have this number of eggs in order for me to help you. And you need to know what that number is at the center that you're at. For me, if you have one follicle, one egg, that means one chance, and I will give you that chance should you want it. But not everyone has that type of philosophy when it comes to treating their patients.
Thank you, Dr. Aimee. Dr. Aimee, there is one other question here that popped up, that if a couple are in their 20s and they would like to freeze eggs, but they are married or they are together, should they freeze eggs or should they freeze embryos? And if the female, dependent, she has endometriosis and she has like endometriomas in both ovaries, what are your recommendations? Eggs or embryos or both?
Again, it just depends on what the relationship status is. If he for sure like your guy and you guys are going to have babies together, then I would do both. If you're like, I don't know if his sperm if his sperm is deserving of my eggs, then don't make any irreversible decisions that will tie up your eggs with a loser. I always tell people that no one gets married thinking that they're going to see their kids 50% of the time. And no one does. No one's like, oh, I can't wait to have a kid that I can hand off to some stranger to take care of. Right? Especially when you've gone through fertility treatment. And I've seen it, unfortunately, far too often. And I know Dr. Nezhat mentioned my kids. I have 2 girls and 2 boys. I've taught my girls. I said, do you need a husband to have a baby? And they go, no. I'm like, good girls. You just need a sperm donor. And I'm starting a sperm bank. It's called sparklingspermbank.com. It's a joke. I should do stand up. I know. You guys are like, how is she so funny? I don't know. I swear there's no tequila in my coffee. Maybe there is. But my point is, when it comes to making embryos with someone for your future, please think through all the worst case scenarios, get legal paperwork signed ahead of time so that if, let's say, you guys split up, you are still going to be allowed to use those embryos. Otherwise, freeze both, because you don't want to be in a sticky situation.
Thank you very much, Dr. Aimee. Dr. Aimee, I didn't know you are a stand-up comedian also.
I
That
am.
was great.
I have
Another talent you have.
We'll do another webinar later and it'll just be pure jokes, all fertility related, because this is pretty heavy stuff. And I try and make it super lighthearted. My patients, I hope, they're not crying because they're sad when they come here. They're crying because they're laughing so hard at some of the silly things that I say to liven up the mood.
That's wonderful. That's wonderful. No, I just great that we discovered this side of you. And Dr. Aimee, one other question here that I have is it, do you recommend that men also freeze their sperm, and at what age, and what is the role of age of the partner in having children, and what are your recommendations?
Yeah, so I have a jingle. It's always nice to have sperm on ice. So I have 2 sons, and I can guarantee you that their sperm will be frozen probably by the time they're 21, and I'll just put it away for them until like they may or may not use it. And the reason is, we have COVID, we have pandemic, it kills sperm for a lot of people for months at a time. So that's one reason to freeze sperm. People are delaying childbearing. If I see a guy at 50, if he had sperm frozen when he was 40, I want that sperm. I don't want 50-year-old sperm. We know that as guys age, right, you have a higher risk of having embryos that are chromosomally abnormal and a whole bunch of other diseases. And I don't want to scare you guys in talking about those things, but those are things that ideally people don't want to welcome into their family. And so I try and create as much as I can healthy families. And I want to teach people about what they can do ahead of time to give themselves the best chance. So if you have, let's say, endometriosis and you're thinking, well, I'm not ready to do IVF yet, but we're thinking about it, maybe in 3 years, maybe just get some sperm on ice now so that you can use that sperm in case something happens. You just don't know about what the future holds. And, right now with COVID, I've had cases where I've had to cancel them, and it takes 3 months for the sperm to come back to life because of what high fevers can do to guys and their sperm. Sperm's very sensitive. Eggs, not so much. We can get COVID and our eggs are going to be fine, but men, not so much.
Thank you. That is insightful. What is the oldest couple that you have had? If you can just mention the name, how old has been the male partner, the oldest, and how old has been the patient? Not the same couple, but in general, your experience.
My oldest female partner, my oldest female patient, 52 years old. My oldest male patient in his late 70s. So, for me, I don't discriminate against anyone based on age. People are pretty reasonable when they come to me, and they I always say, you're so smart. You must be so intelligent because you came to me as your doctor. And so they're pretty practical out there. And so they come to me because they know they're going to get the real deal. They're going to get hopefully what I'd like to think of as good advice. And most people listen to me. And so, when I say things like in their late 70s or, women in their early 50s, we're doing things that are safe and good, and we're building healthy families with lots of tests, lots of testing to make sure we're doing the right thing.
Thank you. So, Dr. Agarwal, Dr. Lee, and Tavallaee, do you have any more questions from Dr. Aimee?
So there is another question. I think we have touched on some of it, but someone actually asked kind of about failed IVF and an elevated receptiva BCL6 of 3.8, and they're undergoing suppression with agestin and letrozole prior to perhaps another retrieval, and also in the presence of a low AMH. I think my question would be, in counseling with that patient, where would talking about surgery be part of that counseling for you, Dr. Aimee, and where would you have that conversation, and how would you kind of counsel your patient for options moving forward?
Yeah, I've learned a lot over the years about how important it is to make sure patients that you describe make more embryos. And make more embryos before you start the suppression process. Because if, let's say, you've gone through 2-3 months of suppression, I guarantee you that you're not going to have as good of an IVF cycle, especially if you're older with a low AMH, than you would have had 3 months prior. So before you even start that, I say make more embryos, because your BCL6 level is telling me that we might have implantation issues, even if we do all the things that we're talking about, like suppression and or surgery. And then I always tell my patients that my goal for you is to be a parent with your own DNA over you carrying the pregnancy. And so I want to do everything I can to make sure you have a baby with your own DNA. And I don't want to roll the embryos like people talk about rolling the dice and just see what happens. So then I want to be very thoughtful about the approach we take and include a conversation about doing surgery as well. So if, for example, you just have 1 embryo left and that's it, and we're going to talk about, should we do more cycles to get more? If we've already done the number of cycles that we need, then if there's just 1 embryo, I think it definitely makes sense to talk through surgery and suppression. And then I always say this because these are the conversations that people need to have before they transfer, before a negative pregnancy test. What would you do if this transfer didn't work? Okay, everyone remember that. All the audience out there, remember this. Talk to your fertility doctor and say, hi, doctor. If this transfer doesn't work, what else would you do for me? And if they say, well, we should consider surgery, and you say, but I only have the 1 embryo, why don't we consider it now? Because people get really angry when they learn that there could have been something else that they could have done to give themselves the best chance of pregnancy for their 1 embryo. And people make assumptions that the doctors make assumptions that maybe the patient wouldn't do surgery. She doesn't want to hear about all the other things. But my patients, they want to know every possible scenario. They want to know every single thing they can do to give themselves the best chance. So no matter what we do, I will always say to them, if this doesn't work, we made the right decision together, and we can never look back and say that we could have done something different because we were so thoughtful. And patients understand that. They say to me, Aimee, no matter what happens, I know we did our very best, and I know we thought through everything up front before we made the decision to do this. So if it doesn't work, at least I know we tried.
Dr. Aimee, thank you so much. It has been a true pleasure and privilege to have you. This is why we see all of your patients, they love you. It has been very wonderful to have you in the program. We'd like to thank also Dr. Agarwal, Dr. Lee, and Dr. Tavallaee. And also we'd like to thank all the audiences and viewers around the world for their interest in endometriosis, for their interest to raise awareness about this social issue. We wish all of you the best, and we will meet you next month, February the 26th, I think it's a Saturday, at 10 a.m. again here to continue this program make sure some of the patients next time are hopefully are all available to hear their stories. And thank you again, Dr. Aimee, and have a great week. Bye-bye.
Bye, everybody.